Okay, folks, thank you for coming. My name is Ben Hilliard, and we had just quickly prepared a 4-question Menti poll. And if you haven't used that before, you can either do it by your desktop or your cell phone, and I'll give you instructions in a second. Bear with me, and somebody give me a heads up if we get the Menti poll going.
Welcome to the world of technology. While Ben is pulling that up, I know that we have some new faces on today. So want to again give hellos, good morning or good afternoon, depending on where you're logging in from. My name is Monica Harrison. Myself, Laura Sadari, and Ben Hilliard are your leadership team this year for the CFHA, Collaborative Family Healthcare Association, CoCM, Collaborative Care Special Interest Group, or SIG for short. So we are leadership this year for your SIG group, so we welcome you. We are a very informal group, so you can be on camera, eating your snacks, hydrating, doing not everything you would probably do. The things it's okay to do in front of other people, feel free to turn on your cameras and do those things. We welcome that. We love to see faces, but also understand if you're multitasking and you're not willing to show your face too. No harm, no foul. So want to give major thanks to our 2 individuals today who are going to be just kind of sharing some tidbits with us and also are willing to answer your questions that may come up. So for today, we're going to be having conversations around collaborative care and billing and advocacy for those collaborative care codes out there. It's been one of the topics that you all have mentioned multiple times to us that you just kind of want to talk about, want to know that there's other people in the trenches too, what's happening, what maybe you could do, some of those things. So for today, we have Becky Yowell with us, and we also have Dr. William Beecroft with us this morning or afternoon, depending on where you're logging in from. So they're going to be sharing and just answering some basic questions that we kind of prepared and want to hear from them based on some of the feedback we received from all of you and other colleagues in the field. And then we will also open up the floor for you maybe to ask some additional questions that you may have around collaborative care, billing, advocacy, what they're hearing out there, kind of that type of thing. And then, of course, as we always say, you all are in the trenches doing the work with all of us together. We're in this together. So we have the mentee questions because we want to kind of know where everyone is and what's going on for you all out there in the field regarding collaborative care. So Ben has his mentee. Ben, you can take it away.
Okay, so real quick, so instructions are, if you go to Menti and there's the code, menti.com, and if you want to use your phone, just use the QR code. Real quick, so just on a just wide basis, what codes are you using for collaborative care processes? Psychotherapy codes, the typical 3 or 4 that are CoCM or others. If anybody could just throw in a brief response to that question, that'd be great. Oh, 96127. For the person who said 96127, is that reimbursed regularly?
That was me, yes. In Illinois, we do get reimbursement for screening for the BHI screening codes. Depends on the payer. It's not great reimbursement, but it's something. So they tell us to keep billing for it.
Got it. Excellent, excellent. Okay. Anybody else? We're going to go to the next one. So tell us some billing success stories or barriers and or challenges. Mm. Oh, that's a big one. Falls under behavioral health carve out. Okay. One thing I haven't seen is 99484.
So I tried to, it's Ashley. I tried to submit that in the last question, but I didn't do it in time. So we
Oh,
do use that in Connecticut.
oh, excellent. Sorry to cut you off there. I wanted to get to our speakers quickly. All right, two more. How are you working with your billing and coding team? Is that difficult? Is it a barrier? Is it successful? Oh, the dreaded transition to a new EHR. Oh, fantastic. Excellent. And the last one. What strategies do you use to talk to billing stakeholders or health system leadership to make the business case? Mm. Okay, I'll leave a couple more minutes because I don't want to take up too much of time. Yep, fantastic. All righty. So Monica and Laura, I'm going to unshare my screen, save this for later, give folks just a couple more minutes and pass it off to you. Excellent. Thank you for your input.
Thanks, Ben.
Okay, so we got to see what some of you all are struggling with, which is exactly what we wanted to start to talk about today. Notice I said start to talk with. You will not have everything answered after this call, and things are always and ever evolving. So these suggestions and things that you hear are only as good as whatever time it is and whatever time zone you're in, is what I like to say. Things are always evolving and changing. However, let's get started with hearing from Dr. Beecroft and Becky. One of the things I wanted to ask, and you guys can decide who talks first. One of the things that I wanted to ask, because it's something that continues to come up, is what are like, do you get to hear what the barriers are that people are having around financing and sustaining collaborative care? And if not, where should individuals go to voice those? What are, what's the advocacy that could happen with payers and things of that nature?
I'll defer to you to go ahead and go first if you'd like.
I'm fine either way, Bill. So whatever your preference is.
You can go ahead and go, and then I'll jump in.
Sure. So, hi, I'm Becky Yowell. Actually, I'm the what am I? The Director of Reimbursement Policy and Quality for the APA, the American Psychiatric Association, and we've been engaged in helping to support collaborative care for quite some time now. So it's great to be here with you. I think honestly, I do feel like some of the biggest barriers is really sort of either information or misinformation that's out there, and just in terms of what you can and can't do. I know that the code structure itself can be a challenge, and some other things. I think broadly, Monica, and that's kind of how I interpreted the question when I read it yesterday. Is I think. We all know how good, we've seen the evidence, we're supportive of the model. And really, I think for implementation, you really need to get that messaging out and the buy-in from primary care, which that is not who we are. And so it's really trying to influence primary care in general. Hey, this is a good thing. Hey, we know it's hard work. Hey, we know it'll take some changes in how you do things, but it's well worth it. And trying to assure some level of sustainability, reimbursement, et cetera. So I'm not sure if that I was on point, but I'll turn it over to Bill as somebody who's actually done more implementation.
Okay. Yeah, I'm Bill Beecroft. I'm the Medical Director of Behavioral Health at Blue Cross Blue Shield of Michigan, but my real life before getting in the insurance world in a more full-time role was as a consultation liaison psychiatrist, geriatric certified in general psychiatry in general medical hospitals and inpatient psychiatric units, outpatient practice. I worked in Lansing, Michigan, which is, I call it a big small town, catchment area of maybe 125,000 people. But we had initially 5 hospitals, and then it got down to 2 before I turned over or went into this line of work in 2013. So with collaborative care as a consultation psychiatrist, being in the hospital every day, I did this work for 40 years. And in a small town, people get to know that you're willing to talk with them. I started into an internal medicine residency before I went into psychiatry. So they knew me as a resident, internal medicine resident, and then continued in the same community through my residency and then psychiatry residencies, and then practiced here. So, there was a collegiality to it that they'd ask, hey, I've had this patient on Prozac for a year. They're depressed. They're still depressed. What do I do this afternoon when she comes in? And the thing I would always kind of say is, well, you probably should have talked to me about 9 months ago, but you're talking now, and that's good. So let's look at what we can do, and then help them to be able to go down the algorithm of how to treat major depression. So that's kind of my background. When I came to Blue Cross, we had in our HMO product, we had a number of practices that were in a capitated model. And we were fortunate to have a couple different university settings that had their medical services, especially University of Michigan, and the groups that they had surrounding them in the Ann Arbor community were in many respects capitated. So we had some first adopters. We had 25 practices that were first adopters even before collaborative care was payable. They were doing this on grant funding, but what they saw in a capitated model was that there was a substantial decrease in the overall spend. And that correlated with University of Washington and Ames Center research done at that time, and has been done more and more since then. So that really got me started in that. And then when it became payable in Medicare in 2019-ish, I think it was 19, might have been 18, I was able to make a clear argument based on that information to get this payable in all of our commercial products as well. Very quickly thereafter, we found the difficulties with configuration of some of the codes and how it was done. I can get into that a little bit later, but you have to look at these pieces of it to be able to find the barriers. The coding is a bit complex, but fortunately, we had a really strong provider-delivered care management program in our provider group incentive program. And really, collaborative care is PDCM with a psychiatric consultant and a behavioral health care manager. So it was not that big a jump for our practices that were already involved in PDCM to be able to make the step to collaborative care. And now we have 300 practices, over 1,800 practitioners that we've trained in this model. And it's doing quite well, actually, and continuing to expand this year as well. So that's a quick introduction into the primary barriers and some of where I'm coming from and the things that we've seen.
One of the things that I kind of heard both of you talking about in terms of having to advocate for, or barriers, advocate with the primary care providers or advocating within your organization and some of the barriers that exist. Are there other things other than the research that came out that you use to advocate, or that you have found to be successful, or other organizations have found to be successful in getting buy-in?
Happy to go first if that's all right with you, Bill. I think I think the stories, I think the hearing from people who've done this and who have been successful in doing it, just painting that picture of what it looks like when it's up and going and working well is, I think, for me, that would include like pulling in whatever data, data points, but depending on who you're talking to, you want to keep a simplified message and really highlight the aspects that are the positive outcomes of what's happening in terms of what the impact of the model has on access and outcomes.
I agree. And the things that really worked for me in this was really 3 different main tracks. One, I was fortunate enough to befriend one of our actuaries who had an interest in behavioral health. And he did an analysis of our patient population, how many people had a primary or secondary behavioral health condition and a primary medical condition, and what their costs were. And in general, it parroted the APA's findings and also Milliman's findings early on, that we were running in the range of 24% of our population had a primary or secondary comorbid behavioral health condition with a primary condition. And they were consuming 47%, 48% of the overall spend for the company, which is very close to what Milliman and APA came up with back in the early days. That was very helpful because then that got the attention of the CEO, and this guy had a very good relationship with the CEO. That also coincided with a lot of pressure in those days for access, which even back in 2018, 19, 20, before the pandemic, we were having difficulty with psychiatric access. And I was able to make a comparator to my practice. And I had multiple different roles, but the most I could handle in a practice was about 600, 700 patients. Now, you take the average psychiatrist that's not doing all those other things I was doing and just an outpatient practice, they might be able to handle 1,000. In this model, in working with the folks at Mayo Clinic to get some kind of reality testing, we call it in psychiatry, we came up with it's likely that a psychiatrist could manage or influence the care of 2,500 patients. And I agree with that. I think having done this work, I think you do influence the care. It's not direct care, so it's a different model. But that helped the CEO see the access issue. and be able to make a really good argument that not only, one, are we going to save money on this, because the money really isn't in psychiatry. Psychiatry makes up about 5% of the overall spend for medical care, overall medical care. It's the surgery and the medical side that takes up 95%, and that includes all the pharmaceuticals. So when you make that argument, that really starts to move you forward in systems to be able to see the benefit of that. And we had good research, solid research in the IMPACT trial that really also coincided with that with diabetes. And so that was how I was able to make the economic and other influence there. And then the other third piece is my experience. And in Michigan, it's a big state in the sense that there's 11 million people. It's not the biggest state in the world, but it's still pretty big. But it's a small state when it comes to the medical community. And I had been, many of the residents that I trained were now in other areas in the state. It had relationships with referring patients and taking referrals into my inpatient units from all over the state. So with that, there was a way of being able to influence the medical community as well, that this might be something that's a really good idea. In my training as an internist, before I went into psychiatry, it's the doctor's way or the highway. And in psychiatry, it's team medicine. So being able to show the benefit of that team medicine, that it makes your life as a doctor easier, and then have some successes from our early adopters, that we had some internists that were saying, really following through with this and saying, it changed my life. I was able to work 5 more years, these kinds of things. So it really helped decrease that burnout that primary care sees. Continually, they talk about the burnout, that 90% of the people are burned out. Once they get doing collaborative care and it's really flowing, about 6 months to 8 months in, they say, I like being a doctor again. I like going to work. These are challenging patients, but I have help. Those kinds of things are quotes from these docs. So those are the 3 main, you could say 5 tracks that really helped me to be able to move this forward in Blue Cross of Michigan and in Michigan in general.
Gotcha. Thanks, Bill. Becky, do you want to talk some about the resources you're putting in the chat there?
Sure. So, obviously, I know everyone knows there are tons of resources out there, but there's some new things that the Bowman Family Foundation have been putting out there around collaborative care. So I put the link in there. AIMS has a lot of good information that we've developed, that I've worked with them on, and they've done independently on collaborative care and messaging. I did share an infographic from our foundation's workplace mental health, just on the basics around the business case for collaborative care. So there's lots of information and resources out there if you need some language in order to help engage people in terms of what you're doing. These aren't meant to be, there are tons of other things as well. So,
not exhaustive, but to get you
thank
started.
You. Thanks, Lori. Yep.
To get you started. Well, there was a question that came up around cost savings data. There's a lot of suspiciousness from some organizations about how collaborative care is billed and providing collaborative care, because it is different than what we're used to from a traditional standpoint. And so there was a question around what references that you all might recommend related to cost savings data. Is there anything out there? Where could people go and possibly find it?
Anything you have?
Well, I think I was looking to see if I could find the link to the Milliman report that you mentioned, Bill, but I need to go find, I have the report. I just don't have the link. So when I find that, I'll throw that up there. That was one of the original reports. And then the Bowman Foundation, you'll see there's an update to that information. They also just recently put something out around the reduction of suicidal ideation through collaborative care, which is also a good thing. So I think those are the key ones. Again, though, there may be ones that I'm not aware of, and I don't know actually if you've, Bill, written anything up on your experience at the Blues there in Michigan around impact of cost. I mean, again, part of this will be long-term savings, so I think it's important to understand that, you know, it's going to be savings potentially that will grow over time as well.
Yeah, that's the trick is that they'll grow over time. And, you know, I'll get to that. But to answer the question directly, we have not written anything up. We do have PRISM, which is a University of Michigan spinoff group that is doing our curriculum development along with us and also our trainings. And they've had a really good working relationship with us in developing all of that. But they're also they've gotten access to our data and are now doing a really deep dive data analytics akin to what PenMed has done. I was at a presentation that the PenMed folks had talked about their savings, but the article that they were talking about had been embargoed at that point, and I'm not sure if it has been published at this point and not anymore embargoed. I don't have the reference, but I'm sure a quick Google search about collaborative care and PenMed would give you that. Their results were better than Milliman's. So in that sense, the real world for them has worked out quite well. We found that there's a real tendency in collaborative care to drift back to the old ways. And so we've had to do more work on designating practices and monitoring them, that they're continuing to do and maintain fidelity to the model. So I think that may skew some of our data because we got behind a little bit on that, trying to get people to do it. We weren't so pushing on you have to do it just this way. So that may kind of skew our data in the real world. But it does appear to be moving in that direction that you want it to.
So you both have kind of mentioned long term, you know, that there's the long term cost savings to all of this. And so I'm just wondering if you could talk some about that, because I think there is this disconnect that happens between short term cost pressures that people are faced with and kind of the long term savings and health outcomes.
I guess, you know, from a policy position, and I'll let Bill talk a little bit more with the industry lens. I mean, I really think it's important that you consider savings broadly, or what that means broadly. So not necessarily just in financial savings, but improved health outcomes, better quality of life for patients. Potentially in primary care, helping primary care clinicians have a better quality of practice in terms of how they're approaching mental health and helping their patients. It may ease their patient caseload over time if people are getting better faster, and so that has to be feeling better. From in general, I think it's good, you know, as we've all, if those of us who've had employer-based plans, you know, you may be switching plans from time to time, and you may feel like the plan itself has no incentive to do something like this, since they may not see the realized savings. Should the employer change to a different plan. But overall, I think if every plan recognizes the value here and offering this and ensuring that the overall cost of care is going to go down, that ultimately taking an interest in controlling that cost in a positive way would benefit everybody. So that's my feeling, I guess.
Yeah, there's really a couple, and I'll segue into that one and then kind of go over a couple other things that go to this. But we are arguably the largest insurer in Michigan. We have about 5.5 million members out of 11. So, yeah, that's the rest of the plans need to kind of catch up with us. But we also have a fiduciary responsibility too. And we have a really good base of members that stay with us for life. So we don't have that every year at open enrollment, we have to worry about losing half of our population. We'll lose some, but they'll come back. And, you know, it's kind of a rotation that happens. So with that, that stress for an insurance plan is really helpful to be able to look at population health and what can be really helpful long-term. With that being said, the clinical pathway with this is, and I saw this written up early on, and I've never been able to find this graph again, but it seems to fit, is that in year 0, which is the year before you start collaborative care, a person has a certain level of expenditure or cost. Actually, it's probably in the Milliman document that you find, is probably where I got this. But in year 1, where you start, you really don't see any change in the overall spend. They still do the same sorts of things. You're really in that process of educating, being able to intervene, start getting them well. And even if you do everything perfectly well in a relatively simple case of major depression, it still takes anywhere from 4 to 6 months for a person to really get back on their feet and doing well. That's a lot faster than it used to be, because in primary care, it used to take somewhere, in many of our programs, it used to take anywhere from a whole year to, so 52 weeks, to up to 60, 68 weeks, year and a half before people would get back to normal PHQ-9s. Now, the natural history of major depression, single episode, is about 18 months. So were we making any difference how it was being treated before? Probably not. But if you do things well, that gets driven down to usual times to response is in more of the 6 to 8 weeks, and remission becomes more in the range of 24 to 30 weeks. So a substantial reduction in the length of time that the person is ill. And if they have a comorbid medical condition like diabetes, which we know 70% of people do, various pain syndromes, rheumatoid arthritis, bowel syndromes like irritable bowel, Crohn's disease, these sorts of things, you don't see much improvement until year 2. And then you start to see some gradual reduction of their use of ER, hospital, higher levels of care, imaging, these sorts of things. And by year 3, that year 2 starts to really go quicker. So your slope starts to go up of improvement of their health, decrease on the other side. It's an inverse relationship, decrease in their overall spend. So by year 3, you start to plateau. So this is not an investment of, hey, I'm going to diagnose this person with a PHQ-9, and 3 months later they're going to be on their antidepressant and everything will be fine and we don't have to do anything more and you're done. No, you have to continue working with them, even if it's a backing off into a maintenance level phase of collaborative care for a significant period of time. And that's what I'm trying to find, if there's any literature on the dose, the correct dose of collaborative care. We're getting so many people giving us claims of only 3 claims, so 3 months. Clearly, that's not enough for the natural history, even treated natural history of major depression or anxiety disorders. These are chronic mental illnesses. I know I'm being very broad in this, but in thinking about it, the recurrence rate of depression and anxiety disorders is substantial for many, many people. So if you think of them as another chronic illness, you're actually starting to think more like what really happens. Even though it may not be labeling correct, it conceptually fits the model better. So that's where you get into this thing of, you have to be patient in this. You have to stick with them. You have to stay with the course. If they're not getting better, you change meds, you change again, add psychotherapy, or start with psychotherapy and then add meds. However you and your team feel is most comfortable to do that. But that's the trick, is sticking with it long enough to see the improvement. And again, this does come from Milliman. It's the kind of one of the more difficult things to talk about, but 60-year-old male, 6-year-old single male with hypertension, diabetes, and heart disease, along with major depression. I think they said it was somewhere around $60,000 was the overall spend for that patient per year. Once they had been treated for the major depression to remission, that went down to $12,000, which is about what is expected for that same demographic. Pretty amazing when you start getting those types of responses to your patients in your practice.
Agreed, Bill. Agreed. Well, I'm going to open it up because I want to make sure that there's opportunity for some of you to ask questions. And then, of course, we want transition time so that we're not all bumping up against the hour to our next meeting or patient or things. So, Jen Thomas,
I got a
come
question.
on off mute.
I gotta ask you, Bill. So I love the cost savings perspective. It doesn't seem to be the head turner that we think it should be in clinical care. You know, we see the benefit directly with our patients. When we get in the meetings with the CMO, CFO, CEO, whatever, they go, well, you know, but when I look at your IBH program, I see cost of your guys' salary, and then I see the revenue for fee for service billing for CoCM, but I can't quantify the cost savings in my little health systems spreadsheets in my finance department. So they say, well, yeah, Blue Cross cares and Illinois Medicaid cares, but how do you get with those people? Like, who's the you in each of our states? Because I really feel like that person, if we could get them to that meeting, we would be light years ahead, because Bill is like a unicorn of like this, you know, awesome clinician who's also with the payer. And like, it'd be amazing if we could each have our own equivalent of Bill in our state, because that person could really get the job done to really understand, you know, where we're coming from with cost savings. I don't know, any thoughts on like how to clone you or introduce you to all of your Blue Cross friends in all the other 49 states?
Yeah, well, no. But, you know, I didn't put in that cost savings is various places have a cost analysis of quality of life. Anywhere from $35,000 to $50,000 is what the numbers put on it. So those patients know that you're getting them better. And I think it really comes down to, and I also had a CEO of a hospital tell me one time in a very uncomfortable discussion with me as his employee, that there is no green money. There's red money and black money, but there's no green money. And that's the toughest argument to get around with those folks. That's where that actuary and being able to get him on board really was able to sell that they can talk dollars and they can talk that green money into real money. So that's a big trick to be able to look at in those kind of hospital organizations. And that the other piece is that with the pressure on value-based reimbursement and on capitation or full risk for large populations, basically ACOs that are then taking over 300,000 or 500,000 members for an insurance plan and taking full risk. We've got some in our state now. They see it. So it's really switching the gears of the administration from the old way of thinking and fee for service, that there's this many dollars coming in, there's this much salary, I'm losing money hand over fist here, what am I doing? It's like you're missing the point. The point is you want that patient to cost you less dollar-wise, have more fidelity and like with their providers, and be able to increase the quality of your product, because then you can increase your rates to be able to make that work. So I know I'm giving you the secret sauce, but I don't care. That's what it's about. That's being able to talk as doctors about moving this forward, is being able to have that secret sauce out there. And it's not magic to me. All of you have the capability. It's just you don't know the links to make it happen, and that's what I'm trying to tell you.
Yeah. And is that link like a chief behavioral health officer? Is that like someone in the Medicaid HHS? Like, who is the person we should be Googling or handshaking or like networking to meet to get that face-to-face to say, hey, let's look at the cost savings in a value-based care way, because this fee-for-service argument just doesn't get the job done. So how do you meet those folks? So any tips there?
I think when you're looking at state organizations, you really have to develop that relationship with your DHHS and be able to get an audience with the director, or say the chief medical officer for the DHHS.
Okay.
Those are the people that are going to be able to help you to understand this and to be able to look at it in a different perspective, because that's their purview. I was fortunate. I decided never to go on to become a vice president because I like the position I'm in and I do this. but I'm a mid-level bureaucrat when you really look at it in my day job. You know, you get the people that are at the high level, they're not going to be able to make those choices because of the economics of it. So getting into that place of being able to talk to the person, like in my scenario, that is interested in this, that has a background, I think is going to be really the way to help that locally for you to move forward. And you have to have a champion in your practices. It's like you've been in your practice. You have to have that same person to be able to be the champion of the practice. You get one naysayer, oh, I don't believe in this stuff. I'll send you patients, but it'll be, you know, very few and far between. Ah, that doesn't work. You can't have those folks because it'll contaminate the whole practice. One will contaminate the whole practice.
Thank you, Bill.
Thanks, Bill. Not a contamination, Bill said. Jeez. All right, Patty, say more about your question that you posted in here.
Well, I'm in Arkansas, can only speak for Arkansas. Arkansas Medicaid does not pay right now. However, with time, I keep wondering, what's the barrier? I mean, Arkansas Blue Cross pays the codes, but there's still not much uptake, and we pay just as well. Medicare pays. Is the problem the PCP? And Bill's talked about some of that. Is it the clinic lead? Is it leadership? Is it the biller in the clinic? So, you know, I guess now that I do work for a payer, and everybody says it's the payer who's the barrier. In some places it is Arkansas Medicaid, but so just wanted, it's multifactorial, and I think Bill and Becky have both talked about that. I want y'all to help me solve it in Arkansas.
Well, I was going to say, Patty, as you're saying, everyone says it's the payer, but then, right, like, is it maybe these other things? I think that kind of also falls into Jody's question / statement. It's so funny because you guys' questions are also statements because there's some validity to that, right? Jody, you want to elaborate?
Sure. I mean, we already been doing integrated behavioral health for like 15, 20 years over here, and our physicians and practices have already been through all the stuff you all are talking about here in terms of buy-in. And our payer, in particular Blue Cross Blue Shield, is excited about the potential cost savings, but they, at this point, they just want to see widespread adoption of collaborative care model. They want us to run with it. They know we're already successful with integrated behavioral health using other models. So we're establishing this care arm. Now, our other models of behavioral health using psychiatry codes and here and there, we can't make it work financially. We're way in the red. They only cover about 30 to 40% of our cost. Am I going to run into the same problem with these billing codes as I'm experimenting with it? I'm starting to feel like I'm hearing people say that even when you've got all the people at the table supporting this model, the fee-for-service model in and of itself isn't going to cover the cost. Is that what's going to happen to me? I'm just curious if someone knows the answer to that question.
Let me punt to Becky just to talk some about states and their rates that they are.
Well, yeah, our rates are terrible in Tennessee.
I do think, I guess, I do think it's helpful when all payers are on board and paying. They need to pay a rate that's sustainable. So I recognize Medicaid in states as a big problem. APA pushes, and I will say that Bill's a great example. The Blues in Michigan paid above Medicare to help people get started and provided that implementation support. So I really think, you know, it's the upfront costs and the quickness with which you can get a caseload going and enough bills going in to get you over that hump until you're up and you have a full caseload going and you're covering your costs. So people are successful, I guess, Jody, I want to say that, and they've been able to do this, but I have to say that the upfront costs, and that's some of what we're trying to do with some legislation to get Medicare at least to provide some more upfront costs to help you really get up and going.
That's super super helpful, Becky. Thank you. Really, that just light bulbs are going off.
Front costs are a big issue to get people up and moving. The second piece of that is that case management takes a lot of time. And to get the right level or right person as that case manager is really, really important. We've drifted around all over the place, but I said, you need an LMSW really in that position. An LPC and LMFT, they could do some of that as well, but they're not medically trained as much as the LMSWs are. Of course, that's saying because LMSWs have 6 different training paths. I'm talking about a medical social worker, really is the one that is trained in the medical and the psychotherapy aspects of this. So that's really the perfect kind of person in that place. You also have to set limits on that role, that they're not there to be the therapist, that they're there to do case management. And that helps to be able to set the limits for the patient, but also keeps them doing the case management work to be able to have billable time. CMS did change the 9-4 code to be able to allow for 2 hours a month. We have been pushing at the national level ourselves to get that expanded from the 1. So we think we got a little bit of improvement because we took off any restriction on the 9-4 code for the number of hours. We find that you get a person that has a couple medical problems and a major depression or an anxiety disorder, and it will take you 6 hours that first month to be able to really put together a full assessment, treatment plan, coordinate with the consulting psychiatrist, get the primary care doctor on board, do all of that coordination with any outside providers like a therapist that may be in the community or the workplace, get all of the logistical support of getting their meds delivered by Dividos, getting their logistics of getting to the pharmacy or their therapy appointments. All of that stuff takes a lot of work. And by the time they get to about month 3 or 4, it drifts down to that about 2 hours a month for semi-maintenance. And then later it comes down to about an hour a month. So if your case managers aren't putting in that billing like that, they're missing something. They're not doing all of the case management they need to do to be able to do all of this in a complete and coordinated way. So I would make sure that people are actually doing all the work and billing for it appropriately, but billing for the work so you get reimbursed for that time. The other piece is that we probably need to keep track of that financial overhead and how much that case manager costs. We know a case manager in Michigan costs about $122 an hour for their entire package and all the other stuff. So we need to be generating more than that to be able to make a profit and move forward without the other value-based reimbursement packages and things like that we incent the practice for their overall health. So that's something to keep track of, and then get that information to APA needs to have that, AMA needs to have that, so they can actually set a correct RVU for these codes and make sure that gets something that we can be able to do as a community to be able to encourage that to be right-sized in the reimbursement part of it. So those are some tips on how to be able to get to that next step and the people to do. Trying to build psychotherapy codes isn't going to make it for you. So I would urge you not to do that, go down that path, but to build the case management codes, and then to you could work with a bachelor's level social worker that's supervised by a master's. That way you'd be able to save some money if you went it that way. And a bachelor's level social worker specifically in Michigan can be able to do case management and be board certified by the American Case Management Association to be able to fit that role. So I'm not sure about LPCs and LMFTs, whether they have that same capability as a bachelor's level or not. I don't think so. So some little tips and tricks that may help you with that.
I feel like we could have another hour or more talking about these different topics. Thank you so much, Dr. Beecroft and Becky. this is a piece that comes up time and time again. I think the cost savings case is really strong. We've got a lot of good arguments for that. I think if we can continue to find ways to navigate in this fee-for-service world, meeting, where we're at with how do we capture all those minutes? How do we, make sure that we can get reimbursement to at minimum cover our cost? It will make it easier to overcome that hump. And we gave a lot of great tips of how we can engage with local and national stakeholders, regional as well, to be able to do that. So invaluable guidance, just like what Ashley put in there, and really appreciate all your insights.
You're welcome.
I appreciate having the chance to talk with everybody.
All right, so everybody go hydrate, use the bathroom, eat something, have a snack. You got some more hours to get through the day. Have a rock star amazing day, you guys.
And stay
Thank
in touch with
you.
each other. Stay in touch. This kind of group is where we can learn and grow. So reach out. Thanks, y'all.
Bye.